Hello, my name is Maureen Todd, and with my co-author, Amanda Ginter, we would like to talk with you about our research project titled If They Use Chest, I Feel More Respected, Supportive Healthcare for Trans and Non-Binary Folks. We're really excited to be with you virtually. The current literature is pretty clear that preventive healthcare is linked with all sorts of better outcomes, right? That if you get preventive breast healthcare specifically, this is associated with detecting breast cancer earlier, and that is linked with a greater likelihood of survival. So this is an incredibly important aspect of healthcare. We also know that LGBTQ folks are often less likely to go seek out these types of screenings, to go to the gynecologist for well visits, to get mammograms. And this is for many reasons. Among them, prior negative experiences, fear of discrimination, fear of being stigmatized, fear of being dead named, fear of being misgendered, and also discomfort with the exams themselves, the physical manipulation of the body, those sorts of things. We also know that the existing literature about breast or chest health experiences really focus on people with LGB identities and does not capture the lived experience of folks who identify as trans or non-binary. So the purpose of our study was that we want to understand the ways in which trans and non-binary folks understand their breast and chest health, especially including relationships with healthcare providers. So we wanted to have this phenomenological design so that the voices and complex views of this group could be captured, as they have so frequently been left out of this research. We had several questions as we began the study. The first is that we wanted to understand how our participants thought about their breast and chest health. Was this something that they considered? Was this something that they avoided? And what that process looked like. We wanted to know the preference in terms of terminology for healthcare providers to use. The terminology is currently very gendered, right? Breast self-exam, those sorts of things. And we wanted to know if participants would prefer a different terminology or language. And then lastly, we wanted to focus on healthcare experiences themselves. So what things healthcare providers had done that had been invalidating and unwelcome, and what would make a positive experience? What would make it more likely that trans and non-binary folks would seek out these services as they are so critical to overall health? As I mentioned previously, we used this phenomenological approach so we could really get the lived experience of our participants. This is a retrospective study, so we were asking participants to reflect back on experiences that have already happened. We used an open-ended questionnaire, and we got 23 participant responses in an online format. As we are still experiencing a pandemic, we wanted to make sure that this was accessible to people so that we would not have to do in-person interviews and put vulnerable people at risk. We used immediate data analysis. So we did both text and structural analysis of the data. We used memos, and we used the computer program MaxQDA to further enhance our understanding of the data. As we know, the plural of anecdote is not data, so we had to use some validity strategies to ensure the quality of our analysis. So we really focused on negative and discrepant information. So how did the participants experience this for themselves? Were there any outliers in the data, people who did not have a similar experience? We also clarified our biases as researchers. As both my co-author and I are cis, we had to examine our understanding of this data and how it was impacted by our own lived experience and our own bias as well. And we focused on a really thick and rich description of the data and how we understood the participant quotes. Our participants skewed very young, which is not uncommon for this type of a online format. Participants were between 18 and 51. The plurality of the participants identified as non-binary. Other identities participants noted were agender, gender fluid, trans male, trans masc, genderqueer, or gender nonconforming. Pronouns that people used, 5 participants used they, them pronouns. 8 participants noted they liked he or they, or she or they. 5 used she, her pronouns. 4 used he, him pronouns. And 1 person said any pronouns and did not specify further. In terms of race and ethnicity, our sample skewed white. We had 16 white participants, 1 participant who identified as multiracial, 4 who identified as Black or African American, 1 who identified as Asian American or Pacific Islander, and 1 who identified as Native American or American Indian. Within this phenomenological approach, the first thing that we did was develop a list of significant statements, so things that participants noted that were significant to them. And then we grouped this into meaning units, and then we added a textual description, or what participants think happened, essentially their lived experience. And then a structural description, which is how they think the experience happened. So breaking this into the what and the how. And then this creates a composite description of the essence of the phenomenon. So what was this lived experience for the participants? What we found was that participants' description of their relationship with their chest varied. Some people felt very ambivalent. For example, 1 participant noted, I could feed a baby with them if I wanted, and I think that's pretty awesome of my body to be able to do. I don't like that they cause others to misgender me, though. So there's kind of this ambivalence in terms of the ability of this part of the body, and also that this can cause people to misgender. Other people said, I have a love-hate relationship with my chest. Some people said they felt neutral, right? It's there. No strong feelings for or against, as 1 participant put, this is just a part of my body. This is not something I'm focused on one way or another. Some people noted discomfort or even dysphoria. So 1 participant said, they are something that makes me feel terrible about myself. I feel as if they do not belong to me. I have always felt they are not supposed to be on my body and I want them gone. So this participant noting really strong descriptions about relationship with this part of their body. 1 other person put it very succinctly, I am dysphoric about my chest, right? Most participants reported that they had not yet begun self-exams or screening mammograms. This is not surprising, as this was a relatively young sample, and this is something that people tend to do as they age. Some people noted that they didn't think it was necessary. So 1 person said, to be honest, this is the first time I ever considered that I should do that, right? Again, we can see the age of the sample. Other people said that it would make them uncomfortable to begin this process, right? So I don't like thinking of my chest as something that is mine. It's just kind of there. I feel like doing a self-examination would feel wrong because I don't feel like they belong to me. So you can hear in this participant's quote that the process of the self-exam would feel really uncomfortable because this does not feel like a part of their body. Most participants noted a preference for healthcare providers to use neutral terminology. So many participants noted that they prefer chest to breasts, that this makes them feel more respected, especially considering that even though participants may use other terminology themselves, that the use of the word chest would communicate to the participant that their healthcare provider was not discriminatory, was culturally competent on this issue. So it was a symbol or a sign that healthcare providers were communicating. Other people suggested breast tissue, which further removed some of the gendered connotations with the term breast and created a more medical terminology. Some participants noted that they had experienced harm from their providers. A lot of this was centered around not asking for consent. So if a provider did not ask for consent and touched a participant's body, many participants noted that this compounded their dysphoria, that they felt more dysphoric if a provider touched their body without permission or without warning. Many participants noted that the providers themselves seemed uncomfortable with trans or non-binary people, and that was creating an awkward experience for the provider, which then felt more awkward for the person who is getting the health care. So these were items that were noted by participants that were harmful and things that providers should try to avoid. So our implications, we know that this sample skewed younger. About 74% of the sample were younger than 26, which has big implications for how they think about healthcare in general, right? But we also know that this is a really important time to reach participants, because the younger we can start preventive healthcare, the younger we can set up relationships with a supportive healthcare provider, the better overall outcomes there are. We want to be capturing people while they are young to get these good outcomes overall. We know also that non-binary and trans-affirming healthcare increases the likelihood of self-exams, seeing physicians regularly, and getting recommended screenings such as mammograms and gynecological care. So it's really important that we set people up to have these healthy relationships with their healthcare providers. Future directions that we would like to go. We would like to focus more on people of color. This sample skewed very white. We would like to focus on older samples, as this sample skewed very young. We would want to communicate this information with medical providers and provide them with access to information about terminology, about the importance of asking for consent, especially when touching specific body parts. We would also like to focus on lactation, communication with lactation, support for lactation care for trans and non-binary individuals. And here are a few key citations for our project. Thank you so much for taking the time to be with us today. We're thrilled to be a part of this conference. Thank you so much.